Hello everyone and welcome back to Desert Docs, a junior doctor's guide to Central Australia. As you know from our previous episodes, this is a series all about the unique medicine and working life that comes with working at Alice Springs Hospital. Firstly, I would like to acknowledge the lands on which this podcast is recorded. Desert Docs acknowledges the Aranda people of Mantua. We recognise their custodianship and their continuing relationship with country and that we work on their stolen lands. Today I've got Dr. Will Naughton and Danny Tsai, and we're going to be starting an infectious diseases series within this podcast. Will Naughton is a general medicine and infectious diseases physician at Alice Springs Hospital, and Danny Tsai is a senior research fellow at Flinders University, a senior pharmacist at Alice Springs Hospital involved in antimicrobial stewardship. Welcome, Danny and Will.
Danny's actually just the heart and soul of antimicrobial stewardship.
He's been here for a long time.
He's been here for a long time.
15 years now. 15 years. Just past the 15-year mark.
Yeah.
But no, thank you very much. I'm very flattered with these comments. But no, Will makes all the difference when he comes down here.
We've seen, Danny, you've probably seen quite a few infectious diseases registrars and consultants cycle through, and you've been the pillar standing up against antimicrobial resistance in Central Australia. Is that right?
Danny's going to say no, but he definitely is correct.
And won a recent award, I hear.
Well, he's a Pharmacist of the Year. You've got to pull it out of him for him to tell you.
So let's get cracking, guys. We've got a bit of a run sheet that we mind mapped together that's covering, I guess, a typical junior doctor's experience with infectious diseases and antimicrobial stewardship. And I'm really glad you guys came on because this is people we would be talking to in the hospital. So infectious diseases consultant and registrar, and also pharmacist, about all of our different antimicrobial resistance that we have. Will, just to kind of introduce what kind of resistant organisms we do have, what is the spectrum of antimicrobial resistance that we see in Alice Springs and in Central Australia?
We actually have an incredible volume of antimicrobial resistance. I think two of the key pathogens that we really will be looking to talk about in this series are MRSA and ESBL. So that's Methicillin-Resistant Staphylococcus Aureus and extended spectrum beta-lactamase.
I'm always amazed by how fast infectious diseases people can say Staphylococcus.
When you've said it too many times.
Yeah. You don't shorten it. You give it the full proper Latin name.
Oh, we can call it staph. That's
okay. Okay, so Will, let's start with talking about those examples. Can you give us an example of an MRSA clinical case that might typically come to you on a ward round from the medical ward or the surgical ward?
I was thinking about this with kind of an archetypal case that came in the other day, and that was of a 34-year-old lady from remote Indigenous community about 450 k's from Alice Springs Hospital who'd been stopping in town for the Alice Springs show. She had a history of diabetes. She was obese with a BMI of 32. And she presented with a 5-day history of right upper outer thigh pain associated with nausea. When she arrived, she was found to have this warm fluctuant area over her right outer thigh, with a fluctuant area that was about 7 by 5 centimetres. Fairly promptly identified as having an abscess, and these kind of skin and soft tissue infections are things that present really common to Alice Springs Hospital and in fact make up about 2% of our entire hospital admissions across the year. She came in, was referred to the surgical team. She initially had a low-grade temperature of about 37.8 degrees, was initiated on vancomycin, and then subsequently proceeded to incision and drainage, with copious pus noted intraoperatively, but no involvement of deep structures. Fortunately, she was able to discharge home on day 3 with some oral Bactrim to complete 5 days of therapy, but her isolate subsequently was identified as being MRSA. You know, I think it's one of those things where I have trained in a Melbourne hospital that had an incredibly low volume of MRSA where we were reaching for vancomycin rarely. Right? It was an antimicrobial that we didn't even necessarily need to use for bloodstream infection once a gram-positive coccus resembling staph was identified. You'd do a MEK gene test, you'd identify that they weren't harbouring resistance, and you wouldn't even bother with vancomycin. Whereas here, there's so much MRSA that vancomycin is very much our drug of choice for Staphylococcus aureus.
Can we delineate MRSA and NM-MRSA, the non-multi-resistant MRSA, with sensitivity to vancomycin and usually Bactrim? What kind of nuances are there calling something NM-MRSA rather than MRSA?
It's probably a bit of an old term in that I think it's probably changing in the microbiology space. And so calling things non-multi-resistant MRSA is probably starting to become less common. But The kind of utility of that description is that it means that there's an oral antimicrobial that you have that you can use for that organism. And so the difference between a non-multi MRSA and an MRSA full stop is that the MRSA, you're often left with vancomycin as your primary antimicrobial.
And as you said, Will, and hinted to, that this is quite a common scenario for us. We see skin and soft tissue infections that usually go to the surgical ward for surgical management. In my experience, in my 18 months at Alice Springs Hospital, there's a spectrum of things you can do. You can send someone home on antibiotics, oral antibiotics, and that would be Bactrim BD for usually 5 days. But if they've got any signs of systemic infection or a large abscess that's causing systemic illness, then you would usually recommend that abscess or boil or cellulitis have some IV antibiotic management. So that's the vancomycin we've been talking about. And there is an element of incising and draining in the emergency department. But from my time at Alice Springs Hospital, I found that we prefer these patients to have a general anaesthetic and have an IND with the surgical team because it is markedly painful for these patients. And then we transfer them to oral antibiotics, usually Bactrim again. I just wanted to talk to that very familiar process for a junior doctor, and that is an escalating spectrum of how we deal with these skin and soft tissue infections. And the incision and drainage is usually an abscess, whereas a carbuncle usually is excised. Will, had you ever heard of a carbuncle before coming to Central Australia?
I mean, I had, but I was working as an infectious diseases registrar before coming up.
Yeah. And I appreciate this might be a bit of a surgical question, but can you explain to the listeners what a carbuncle is?
Yeah, of course. I mean, I think we think about boils and carbuncles as a spectrum in that they're both usually hair follicle associated abscesses of the skin and soft tissue. Boils usually have a single head, whereas carbuncles usually have multiple heads and can be quite diffuse and infiltrative.
And you can't just treat that with oral antibiotics because it's not going to penetrate to the site of infection, is that right?
Yeah, and I think it's really important to recognise that these are surgical diseases and that incision and drainage is the mainstay of therapy. And so often you're really using antibiotics to suppress peripheral infections. So if there's an associated bacteremia, if somebody is systemically unwell, if you're worried about spreading cellulitis, systemic antibiotics are really important. But the role of antibiotics is much less so than surgical source control. I think it's really important to recognise that incision and drainage by itself leads to a cure in approximately 70% of smaller abscesses. And so that smaller abscesses is this kind of cutoff of 5 centimetres or less, where adding antibiotics provides additional benefit in terms of healing. But that's only by increasing the rate of cure to approximately 80%. So it's only really a 10% benefit. And so that kind of really just emphasises how important good surgical source control is in this kind of situation.
Right. And Danny, you might be able to speak to this, but in other hospitals, it's fairly uncommon for someone to be sent home with oral antibiotics after a surgical incision and drainage. Is that right?
I think it depends on the actual infection itself. So, for example, after incision and drainage, if you have noticed that there are cellulitis in the surrounding tissues, then it will warrant, another 3 to 5 days of antibiotics to complete the course.
Right.
Yeah. But most of the cases, like if you're talking about boils and abscesses, quite frequently they don't have those surrounding cellulitis. So quite often you can get away with just surgical management, as Will has just mentioned. Yeah. I don't know if you agree with that.
I think so. Yeah, I think it's one of those bits where, part of the complexity of working in Alice Springs is distance. Right? And we have these, for example, the patient that we spoke about earlier who's living 450 kilometres away usually. And there it might be more difficult for her to have routine follow-up, for her to have wound care, for her to have the kind of basic things that we take for granted within an urban centre. And so you might, recognising that there are risks associated with antibiotics, think that ultimately she's going to benefit from having that 10% of additional chance of cure because of the other things that need to come into her care.
And this might be also a surgical question, but we see a lot of recurrence of these skin and soft tissue infections. What kind of factors trigger these infections to initiate in the first place?
The tricky part with this is that once you've had a boil or a carbuncle, we know that you have the existing risk factors already present. We also know that it's really difficult to decolonise people with MRSA. And so there's these big studies that look at decolonisation. that are usually best achieved by having an all-of-household approach to decolonization. And so this is everybody using chlorhexidine washers, surface cleaning, washing your sheets, it's washing your clothes. It's all these things that come together alongside. It's a quite intensive suite.
And treating everyone in the family.
And everybody in the family. And the reality in Central Australia is that households can be much larger. And so it's much more difficult to decolonize a household that has 10 or 15 people in it than it is to have a family of 3 decolonize themselves. And so part of it is that it's very tricky to do those things. And those kind of risk factors for that person to have developed their boil or carbuncle will still be present. So maybe they have diabetes, maybe they have obesity. It's going to take a while to get those things sorted. And ideally, we should do some of that while people are in hospital. But some of that is going to be a much longer term intervention to try and improve.
Yeah.
This is unfortunately something where the social determinants of health are really important. And we're looking at people's housing, looking at their ability to, wash their clothes and sheets is sometimes really difficult in our context.
Yeah.
I might segue to the bacteremia that we wanted to talk about. You guys have some really interesting data that you want to share with the listeners about bacteremia in Central Australia. So Danny and Will, can you tell us why that's important in the context of our topic today and what the numbers actually show?
I think there's probably 2 key papers over the last 20, 25 years here. The first is a paper by Dr. Einsedel et al. That looks at bloodstream infection between 2001 and 2005. So this is ultimately data from nearly 25 years ago, but I think it's informative for where we are today in that at that point, the rates of bloodstream infection in Central Australia were amongst the highest reported worldwide. The incidence of bloodstream infection amongst our Indigenous population was nearly 20 times that of the non-Indigenous population of Central Australia. But I think it's really important because at that point, every year, nearly 2% of Aboriginal adults aged over 29 had a life-threatening bloodstream infection. Right? And that's every year. So there's a subsequent paper that was a follow-on from this published by Dr. Ko et al. That looked at bloodstream infection from 2014 through 2018. And even then, you still see a rate that's 10 times higher in Indigenous people of Central Australia compared to their non-Indigenous peers. Importantly, the mean age of people at the time of their bloodstream infection, as well as the mean age of death for those people, was nearly 10 years difference. And so Indigenous people were dying 10 years younger and were having their bloodstream infections 10 years younger. And so this is a huge burden of disease. I think the important thing to take away from that one is that they're all kind of pathogens that we see very frequently in Alice Springs. The majority of the pathogens were E. coli, which would cause nearly a third of infection, Staph aureus, which made up about 17%, and then Streptococcus pyogenes, which was about 12%. And so they're kind of organisms that we're seeing quite a lot of. I think that's also important to look at the difference across these 2 papers that's looking across a decade of time span, is that in this initial paper, so in this study that looked at bloodstream infection from 2001 to 2005, the rates of MRSA amongst Indigenous people of Central Australia was 29%. But then you jump forward to 2014 to 2018, and that rate now is 57%.
Wow.
And so that's a huge difference. And in fact, we've got unpublished data that shows that within Alice Springs Hospital at the moment, you have nearly 60% of bloodstream infections with Staph aureus being MRSA.
Wow.
What Will has just quoted was based on a study that we are conducting right now. But when you look at the antibiograms around the same time, the MRSA rates are sitting at about 50% at the moment. So when you look at the bloodstream infections, the MRSA rate is actually higher. When you look at the overall MRSA resistance rate, it was first monitored back in, I think, 2006. And back then, the antibiogram is showing us that the rates of MRSA was about 20%. So from 2006 until now-ish, it has gone up from 20% to 50%. So according to a study which is published by McMahon, they actually found that the rate of MRSA in skin soft tissue infections is almost 60% as well. And then they actually found that most of these pathogens, they actually carry PVL. It's a type of virulence factor in the past, and it's been shown to be associated with a worse outcome. But the publication in Alice Springs, it actually didn't show worse outcome, but it's associated with pus forming type skin soft tissue infection. Up to almost 90% of our complicated skin soft tissue infections requiring surgical intervention, they all carry PVL. Yeah. So it's a fairly problematic issue that we have to have Staphylococcus aureus isolates carrying these virulence factors. Yeah. Staph can make you really, really sick, especially once it goes into the bloodstream. And so that's why if patient comes in with sepsis, then quite often you have to empirically give vancomycin due to the high rates of MRSA. But we are also seeing some issues with our MRSAs and our Staphylococcus aureus being resistant to other common antibiotics that we use for MRSA, such as clindamycin and Bactrim. Yeah, so that's why I think it's really important for us to think about, the empirical agent that I'm using, whether it can give our patient adequate coverage. And also, we have to be even more careful about the broad spectrum antibiotics that we're using that can actually induce these resistance down the track as well. Yeah.
Why does using these broad spectrum antibiotics induce antimicrobial resistance?
So when you go back to infectious diseases 101, when you expose antibiotic to the environment or to a host, then generally you will kill off all the bacteria that are naturally sensitive to it. But then within your whole colony, there will be some bacteria with naturally resistant genes amongst them, so they will not be killed off. But once you kill off all the other bacteria that are naturally sensitive to the antibiotic, then it actually provides space and nutrients for the isolates with the resistant genes to proliferate and then to multiply again. So that's called natural selection. Yeah. So that's why the broader the spectrum of antibiotic you use, the more likely you are going to select out these bacteria. However, in our situation, we have a few difficulties in terms of treating our patients because of, like what Will was saying earlier, a lot of our patients are living at 500, 1,000 k's away. So their access to the hospital facility is actually quite difficult. So imagine someone who started showing a sign of sepsis in about 700 k's away. It's going to take time for the plane to fly out to them and then for the plane to fly back. So quite often, it's understandable that clinicians and nurses in remote communities would use broader spectrum antibiotics. There are also other concerns, such as there's an antibiotic that you probably have heard of, azithromycin. It's probably one of the worst antibiotic in terms of its ability to induce resistance. Because azithromycin stays in the body system for a very long time, it's got a half-life of about 3 days, which means that once you take a tablet, it will probably take you about 2 to 3 weeks to completely clear of it. But the longer you expose the host to this antibiotic, the more likely it is you're going to induce resistance. And because we have an epidemic for trachoma in Central Australia about 10-15 years ago, we have used a lot of azithromycin. We also have used azithromycin for many, many different indications because of its ease of use. Quite often for many indications, you can just give it, give one tablet once a day for 3 days or just as a step dose. So it becomes a very, very commonly used antibiotic. Quite often, when a bacteria develop resistance against azithromycin, quite often they will automatically be resistant to clindamycin as well. And we believe that's one of the reasons why we're seeing such a high rate of clindamycin resistance in Central Australia, which is around 35 to 40%, comparing to about 15% across Australia.
Thanks, Danny. That was incredible information, and I didn't know that about azithromycin as well. And it's less frequently talked about in Alice Springs because we do focus on the NMMRSA and the ESBL. Just to recap for the listeners, we've talked about 2 reasons why there might be more antimicrobial resistance in Central Australia than elsewhere. The first is the difficulty with decolonisation, and the second is due to the remote nature of our patients being started on broad-spectrum antibiotics and providing that environment for resistance to occur more so than in a narrower spectrum antibiotics. Are there any other reasons that we're missing, Will and Danny, as to why there is more antimicrobial resistance here than elsewhere?
I mean, I think it's all ultimately about volume of antibiotic exposure. Right? And we're looking at huge volumes of antibiotic exposure. I know I was listening to your chat with James, the pediatrician, and I think
This is so meta.
Look at this. It's a podcast within a podcast.
Yeah.
And, I think it's really important to recognize that if you look at skin and soft tissue infection in Central Australia, there's a study that looked at kids under the age of 1, and the majority have had impetigo by the time they're 1 year old. Like that's like more than it. There are some communities where it's up to 80% of kids have had it by the time that they're 1 year old, and that's Streptococcus pyogenes, so Group A strep, but it's also MRSA. And so if you're getting antibiotic exposure early for these concrete indications, you can imagine that if you're already having antibiotic exposure at 1, that's going to build up across a lifetime as well. And then add in the fact that you're also looking at these community-wide administration of antibiotics for things like trachoma, large volumes of antibiotics for pelvic inflammatory disease, or for sexually transmitted infections, or for pneumonia, for respiratory indications. You can kind of see how all of this is building a huge volume of antibiotic exposure.
And also crowding as well.
I mean, all of it is kind of based on that, right? Like this is why do infections happen? It's because of these causes of causes, the things that underlie the reason that we have infection. The reason that people are more likely to be infected is because the milieu in which they live means that they're more likely to have that happen. The milieu in which people live, I think, maybe is probably a better way to say that.
Okay, so now to maybe where the meat of this episode might be, which is how to prescribe vancomycin as a junior doctor. And I was lucky enough to have a orientation lecture by Danny, who took me through all of this stuff. Danny, if you can run us through the principles of how to prescribe vancomycin and what adjustments we need to make based on weight and renal function, that would be fantastic.
Thank you. Yeah. Give me 2 hours. Okay, no. So in terms of vancomycin, vancomycin is a very interesting medication. It's got a very narrow therapeutic window, which means that the therapeutic concentrations aren't very far away from the toxic concentrations. So that's why we need to do therapeutic drug monitoring. So when you talk about antibiotics, bacteria killing properties, in general, you can divide it into 3 different categories. So one is called concentration dependent, which means that you need to achieve a really, really high concentration, and you don't have to worry about dosing again after 24 hours. So something such as gentamicin fall in this category. But there are also other ones called time-dependent antibiotics, which means that you have to give multiple doses throughout the day to maintain the concentration above the MIC for as long as you can. That will maximize killing for those antibiotics. So things like your beta-lactams like penicillin, cephalosporins, and carbapenems. But the third type, it's called AUC-dependent killing. So that's the category that vancomycin falls under, which means that both time above MIC as well as the peak that you achieve, they're both important. So how we monitor the levels is dependent on the area under the concentration time curve. So imagine, there's an X and Y axis, and your X is time and your Y is concentration. And then imagine that you give a dose and then the concentration goes up. And then gradually the concentration will come down over a curve, right? So all the area under that is called area under the curve, AUC. All right. So for vancomycin, ideally what you want to achieve is an AUC of 400. And that's very, very difficult to measure in the clinical setting. There were some studies that correlated an AUC of 400 to a trough concentration between 15 to 20 milligrams per liter. All right, so junior doctors are trained to just give vancomycin doses according to the guideline and then measure the trough level after 3 doses. And if the trough level falls between 15 to 20, then that's considered okay. However, this has been refuted. Over the past few years, there were growing evidence to show that the trough concentrations are not a very good way to associate with an AUC of 400. So that's why in the next edition of therapeutic guidelines, it will start making this recommendation, which is to do AUC monitoring. In terms of the dosing, we still do recommend for patients who are in sepsis or who are in septic shock, we still recommend these people to give a good loading dose just to make sure that they achieve good therapeutic concentrations before you start to think about the maintenance dosing regimens. So for now, it's pretty much business as usual until the new guideline comes out.
Yeah, there's going to be one to watch for the new therapeutic guidelines.
Great.
Which Danny has been involved in as well. So
yeah, I will just flag for any junior doctor coming to Central Australia that the guidelines on the intranet at Alice Springs Hospital are fantastic. So it kind of walks you through, as you said, Danny, the loading dose as well as the maintenance dose, which is based on weight and renal function, so creatinine clearance, as well as when to measure those trough levels. And luckily we'll have Will and Danny come and visit you on their ward rounds and help you with a dosing based on whether that trough level is above or below the window that we're achieving. I might just add here from my experience when I've been monitoring trough levels on the ward looking after surgical patients, always check when the trough dose was taken. So usually the blood has a time as to when it was drawn, and check that against the time that it says on the electronic medical record that the vancomycin was administered, because you're aiming for a trough within 60 minutes of the next dose being given. So you'll actually give the next dose before you know what the trough is, and it's after you know the trough level that you'll adjust the dose that's 6, 12, 24 hours later. And that timing of dosing is also dependent on weight and renal function. We won't go through the numbers on the podcast because it's really well written in the guideline. Something else to quickly add is the adverse effect of red man syndrome.
This is one of my bosses who I worked with has argued that it should be red person syndrome. Look, I think this is to recognise that you can get mast cell activation with administration of vancomycin. It's largely rate dependent and is not in and of itself indicative that the patient has an allergy. You can usually give the antibiotic subsequently with a slower rate of administration, have it be well tolerated. But the red person is pretty descriptive. These are people who end up full body erythema, basically.
I think it's time to move on to Bactrim. Bactrim, in my experience, is our vancomycin step down. It's our oral step down for IV vancomycin.
Bactrim is one of our workhorses. We use Bactrim a lot. You'll see it used for MRSA. You'll see it used for impetigo. It's certainly something you'll be prescribing a lot on the surgical ward for patients to go home with. I think it's important to recognise that there have been studies that have demonstrated that Bactrim works as well as intramuscular benzathine, benzylpenicillin, or oral clindamycin for treatment of uncomplicated skin and soft tissue infections, as that includes things like impetigo, cellulitis, and simple abscesses. And in fact, that you can use it for group A strep as well. So you will find that there'll be sometimes concomitant with our MRSA as the cause of abscesses. Sometimes you'll find some group A strep there. And we know from our study data that you can use Bactrim in that circumstance. Yeah. I think it's probably important to recognise Bactrim does have a significant risk of severe cutaneous adverse reaction. So you'll know it as DRESS or AGEP or TENS. And that it does mean that it is one of those things where we do need to consider that when we're prescribing it for our patients and make sure that we're monitoring it. The study coming out of Darwin was looking at protracted durations of Bactrim for myeloid predominantly, which we often give much shorter doses and at much lower, shorter durations and at much lower doses, but did find a significant rate of severe cutaneous adverse reaction there. And so it is one of those things to be mindful for in the future with our cotrimoxazole prescribing.
Yeah. So thanks, Will and Danny. I think we covered quite a lot of important content for antimicrobial stewardship and antimicrobial resistance. To summarise to our listeners today, we talked about NM-MRSA and common presentations in skin and soft tissue infections. We talked about bacteremia in Central Australia in terms of the rising rates, what the causative organisms are. We talked about the rise of MRSA and clindamycin and azithromycin resistance, and then we discussed vancomycin dosing as well as Bactrim. I hope that answered some questions or gave new listeners insight into, you could say, weird and wonderful infectious diseases arena we have in Central Australia. And we'll catch you next time. Thank you again.
Thank you.
Thanks, Indi.
Desert Docs, a junior doctor's guide to Central Australia, is an anti-health media podcast produced with the help of ACCC Studio.